can move the slide.
Good morning. First, I'd like to thank Benjamin for the kind invitation. It's really a great pleasure and honor for me to talk to the French vasculitis group, which I've been following the studies for many years. In fact, try to imitate it in Turkey, at least with the Takayasu area in the beginning. Now we are trying to form a larger group also. Today, I'll talk about Takayasu's arthritis. It's I know, a rare disease in France, but definitely as vasculitis experts, you are the ones who will be reached, and always a difficult decision and for diagnosis and management. My only main disclosure will be about the upadacitinib study. The results are not available yet, and I will not mention about that. I'll talk about the diagnosis and classification, assessment and management of Takayasu. As you know, it's a granulomatous arthritis predominantly affecting the aorta and its major branches. It's important that it has no involvement of small vessels. You don't see digital infarcts, for example. Onset is usually less than 50 years, but the recent ACR classification criteria put the limit to 60 years. With female dominance, incidence is around 0.5 to up to 4 in the East Asian populations. We think it's a bit more frequent also in the Middle Eastern races, but there's not much data other than Turkey. The prevalence is up to 40 per million in Japan. It's a slow progressive disease with increased mortality. Now, what are the red flags and symptoms in Takayasu? First of all, we frequently ask for unexplained acute phase response and shown out to be Takayasu when the PET was done. The carotidynia, a very specific symptom. Of course, discrepant blood pressure, hypertension, absent or weak peripheral pulses. Most of these red flags are related to the upper extremity, but we should always be aware in the abdominal features, which can be undiagnosed until that moment. The vascular symptoms, major ischemic events, and carotidynia are the most common in the early onset. Although it is said to have a three-course disease with constitutional symptoms, vascular symptoms, and at the end, major ischemic events, this doesn't go like this always. And the patient, only about 20% have a triphasic disease, and the patient can come directly after a claudication period with a major ischemic event or stay in the vascular symptoms part only. Interestingly, in a study combining Chinese and Italian data, it was shown that the involvement of the vessels is gender-related. As you can see here, the abdominal features are more dominant. The blue is the males, more dominant in males, whereas upper aortic involvement and the aortic branches are involved more common in females. That's an interesting issue to be explained. We know that early diagnosed Takayasu has more inflammation, but we also showed that it also has less damage. For example, in our inception cohort that we are following for the last 5 years, the patients in the first 2 years of their disease, when we compare it to our retrospective cohort, limb claudication and carotidynia was much more prevalent, and also mucocutaneous features like erythromanodosum. People don't remember it, but in the early cases, it reaches up to 20%. On the other hand, only 1/3 of the early cases have pulse loss, and most of them have limited disease, type 1, compared to the whole aorta involvement. Now, how do we image these patients? The EULAR formed a group, and I'm part of it, recommendations for the use of imaging in large vessel vasculitis, both in JCA and Takayasu. In the recent update, in fact, compared to the previous one, it hasn't changed. It is offered that MRI should be the first imaging test to make the diagnosis, to investigate the mural inflammation or luminal changes. FDG PET, CT, or ultrasound may be used as alternative imaging modalities. However, we are not using conventional angiography as the main method anymore unless an urgent intravascular intervention is planned. So for the diagnosis, MRI should be the first method. The methods can improve our diagnostic issues. For example, I'll mention about the pulmonary involvement. It's said to be around 6 to 19% in different series, some of them leading to pulmonary arterial hypertension. This is a case from our series where a chronic thromboembolic hypertension developed and the patient required a surgery, embolectomy. And the mortality seems to be higher in these both pulmonary involvement and pulmonary hypertension cases. When we look at our CT angiogs recently in 72 patients, we observed an 18% involvement. And it seems that in patients without an acute phase response or symptom, there's not much vasculitis. However, if the patient has both symptoms, chest symptoms, and acute phase response, pulmonary vasculitis rate reaches up to 60%. So in any patient with chest symptoms, and again, an unexplained acute phase response, we should also look for the pulmonary involvement. And there is some associated diseases with Takayasu. And the clues from it come from the genetics. For some years, we are working with Amr Savalha from Pittsburgh University and formed the largest group of patients with Takayasu with over 1,200 patients from 5 different ethnicities. And it was shown that Takayasu has the closest relationship in terms of genetic associations with spondylarthropathy group disorders, especially inflammatory bowel diseases. And this is supported by some clinical data, such as we observe inflammatory back pain or axial spondylitis between 7 to 20% in different series, inflammatory bowel disease increase, and both psoriasis and erythromanodosum are observed compared to the general population. And in these patients with spondylarthropathy features, there is usually an early onset and a higher biologic use. And there are mimics, of course. There's a long list of mimics with especially aortitis, such as infection vasculitis, syphilis, connective tissue or IgG4-related disease, sarcoidosis, congenital diseases, Behçet's aortitis. But to me, the most important one in the differential diagnosis is atherosclerosis. This is a case referred to us, a 35-year-old female with dizziness and chest pain. There's a bruit on the right subclavian artery. This is the main reason these patients are usually sent to us in the recent days, with occlusion of carotid arteries, with extensive coronary involvement, CRP mildly elevated, but she's a smoker with hyperlipidemia. So at the end of the day, we decided that this patient has an accelerated atherosclerosis. Can we differentiate atherosclerosis from Takayasu? There are helpful clues in the imaging. The involvement stenosis is mainly in bifurcations and osteums in atherosclerosis, where it's more in proximal arteries. Abdominal involvement more common in atherosclerosis, whereas thoracic more involved in Takayasu. But most importantly, there are linear calcifications and hotspots in CT and PET compared to a linear diffuse involvement in Takayasu. However, these two can be together when we look at our series for the involvement of especially iliofemoral arteries, which is not common in Takayasu. It's associated with the older age, male gender, and smoking, traditional risk factors. So there are cases both in males and females associated with accelerated atherosclerosis added to Takayasu. Recently, NIH group, Peter Grayson and colleagues, defined some angiographic clusters in Takayasu and JCA. When they analyzed the VCRC cohort and the DC-VAS cohorts, they defined 6 different clusters. The first three are more common in Takayasu, the other three more in JCA. In the Takayasu group, the cluster 1 is defined as mainly the abdominal aortic involvement, the renal arteries, less upper extremity involvement and carotid. The second cluster is mainly symmetric involvement of carotids and subclavians. And the third one is usually one-sided left subclavian involvement. And almost all patients in their series fit in this group. Recently, we compared this data with the first published Indian and North American data in Turkey. It seems like in India, the cluster 1, the abdominal one, is the most frequent one, whereas in the North American and the Turkish series, it's usually the clusters 2 and especially 3, the milder one, with usually one-sided left subclavian involvement. It seems that this is related to the age. When we look at our childhood onset Takayasus, which is not very common, but an interesting group, about 50% presents with abdominal involvement. In fact, these are usually young adolescents or children, or usually 10 years old, investigated for fever of unknown origin or fever of inflammation of unknown origin with acute phase response, and in the PET turned out to have abdominal involvement. In the later adult series, type 3 is more prominent. And it seems that these clusters do not change, at least in the short term, too much. It's only about 1% during 3 years of follow-up in the North American and 13% in the Turkish series. Especially the cluster 2 with the bilateral subclavial involvement seems to be associated with relapses. And this should be investigated more, these clusters and their prognostic value. For the classification, for many years, we used the ACR 1990 classification criteria, as you know. And this criteria mainly is dependent on the upper extremity involvement. In the original series, it is said to have around 90% sensitivity and 97% specificity. However, this series are formed comparing only JCA as an important disease for Takayasu, but mostly with other small and medium vessel vasculitis. When this criteria were tested in the DCVAS registry, the sensitivity got lower. However, it's still a very specific criteria. Now, as you know, 2 years ago, ACR and EULAR classification criteria is published also for Takayasu. This criteria aims to first exclude any other small or large medium vessel vasculitis. Alternative diagnosis should be excluded and only used for clinical trials. So it is mainly aiming to differentiate between medium vessel, like PAN, or GCA. Age is selected as below 60, and there should be an evidence of vasculitis on imaging. And when you added the imaging criteria, it definitely seems to have increased the sensitivity. When you look at the development and validation sets, it's around 90% sensitivity and over 95% specificity. However, as in most criteria sets, when they are tried to be validated in the real life, the values change a little bit. This is a series published last year, again, together with the Italian colleagues and Indian patients. And in this series, there are 200 controls, and about 2/3 of them are extracranial GC. So it's more like to a real life comparator group. And it seems that the new criteria has about 63% specificity in this set. Sensitivity is definitely better than the ACR criteria, older criteria, but the specificity is a bit problematic. So they suggest that when the cutoff points are increased to 6 or 7, there is better sensitivity and specificity. However, as you know, when these criteria are published, usually they are not change too much. However, some interesting observations are coming out. For example, recently, Dr. Misra from India compared the patients without pulse loss or before pulse loss happens in early cases, compared the patients with pulse loss. And it seems that in this group, the ACR early criteria has only about 80% sensitivity in the pre-pulseless period, whereas it's 92% in the new criteria. So new criteria seem to definitely get the abdominal involvement better. And to show the disease course, it seems that in their patients over a follow-up over 20 years, the patients without a pulse loss do not develop probably subclavian involvement later on. So that's a different subset seem to be compared to the standard subclavian involvement set. And it seems that the patients with this subset, without pulse loss, has a better survival compared to the other group. So, assessment. For many years, we used, still in the clinical trials, the NIH definition. There should be the presence of systemic signs or symptoms, which is a difficult issue always in the clinical trials. Signs or symptoms of vascular insufficiency, claudication, absent pulses, bruits, elevation of acute phase response, and especially new vascular lesions in imaging. And it's used over 60% of the studies in the literature 10 years ago, still the same. In this assessment part, the new ACR VCRC guidelines have some interesting suggestions. First of all, they suggest that they recommend adding inflammation markers to the clinical monitoring, as we routinely do in the daily practice. However, they then suggest that in patients in apparent clinical remission, but only with increased acute inflammation markers, they recommend clinical observation without escalation of the immunosuppressive therapy. Think of a patient, you got a diagnosis of Takayasu, usually with standard conventional immunosuppressives. And at one point, after 1 or 2 years, CRP begins to increase. First to 10, 2 months later 20, 3 months later 40. But no symptoms. You are supposed to wait still without doing anything. That's not usually happening in the real life. Okay, if it's a mild CRP elevation, if it goes away in the next assessment, that's fine. But I should admit that we are treating patients with high acute phase response after a few months if there is no apparent cause of inflammation, other inflammation. How to monitor with imaging? There, of course, in patients, especially when laboratory markers are not clear, when there's a suspect of relapse with the clinics, MRI can be used. However, there's a discrepancy between EULAR guidelines and ACR. In the EULAR, imaging is not routinely recommended, whereas ACR says that regularly scheduled non-invasive imaging is conditionally recommended in addition to routine clinical assessment. But both of these guidelines come from quite a low level of evidence. Why there's a problem here? NIH now has a very good series of following patients up to 5 years with every 6 monthly routine imaging. And this is their first paper published 6 years ago, where they say that in patients with clinically active disease, MRA and PET are positive in higher rates compared to MRA negative patients. However, there is also a significant subset in clinical remission with active disease. 94% of patients with active disease and 78% in clinical remission had activity in MRA or PET. And because it happens also in the remission period, it's not associated with the acute phase response. Recently, they also published the angiographic progression followed with MRA and PET. And it seems that 70 patients, progression of the disease in an arterial territory seems to be associated with an active PET. However, in over 1,000 arterial areas that they followed in these, in 1.6 years of follow-up, no arterial change happened in 97%. If there is no baseline damage, it's only 1%. If there's a baseline involvement, it's only 9%. So with so low numbers, should we routinely make the imaging? It's hard to say. So there is a new approach to this, and we are part of it. Peter Grayson and Chiara Marvisi, together they formed a Takayasu Arthritis Integrated Disease Activity Index, TIDI. In this one, first it's required that the patient have a symptom in the last 7 days. Claudication, headache, visual disturbance, and also whether if there is a constitutional symptom generally. And then if a PET is done at that point, and if there is a PET in accordance with the symptoms, there's a point given. And any point over 0 is defined to be active disease. So if a patient has only symptoms without any imaging, it's not given any point, and the vice versa. Imaging findings without any symptoms is not accepted as an active disease. And this is recently published, and it seems that this scoring system has a good correlation with the physician global, of course, with the PET imaging and CRP. And they say that it has a 96% sensitivity and 79% specificity compared to physician global. And in patients treated with TNF inhibitors or tocilizumab, a 0 score was achieved in 90%. Now we are comparing this data with the Italian and Turkish data. There will be an abstract in the vasculitis course. I should mention about that. So ACR has another differentiation. They say that when you observe vascular changes identified on imaging, if there is an inflammation findings in a new vascular territory, escalate the immunosuppression. If the existing vascular lesions increase, if the patient is symptomatic or there's active disease on imaging, such as PET, again, immunosuppression is increased. However, in asymptomatic patients without findings of active disease on imaging, a change in the treatment is not suggested. So in a imaging that you find, for example, the subclavian stenosis increase from 30% to 50% without any change in the claudication or acute phase response, they suggest do not change the treatment. So the management. I'll first briefly mention about the last EULAR guidelines, not updated yet. This is a disease that requires a multidisciplinary approach. Definitely, we are in close collaboration with the cardiologists, interventional radiologists, and surgeons. For remission induction, close to milligram kilogram of prednisolone is suggested. And in the EULAR, it suggests to be tapered. The aim is less than 10 milligrams. Now, that's something I find a very high level of steroid dose. For GCA, this is 5 milligrams. And I don't know any other disease today now that the 10 milligrams is permitted. So definitely we should aim for lower doses. Non-biologics should be given to all patients. The options are azathioprine, methotrexate, cyclophosphamide, leflunomide, and MMF. And the patients refractory to these ones, tocilizumab or TNF inhibitors can be considered. Now I'll start a bit of more details about what to choose. This is our first data of comparing conventional two first-line agents usually selected in Turkey, methotrexate and azathioprine, About 65 to 69% remission is achieved. The vascular surgery rates a bit better in methotrexate, and the glucocorticoid reduction less than 5 milligrams is achieved in over 60 to 70%. However, radiographic progression continued in about half of the patients, and the drug survival, as you see, is not too great. Recently, a data came of MMF comparing to methotrexate. And I should mention that all the data I'm showing now are usually open prospective studies, which means is that they are biased to patient selection. And in this series, both drugs have a good rate of clinical responding from 63 to 71%. MMF seem to have a better continuation up to 9 months. And in this series, stabilization of imaging, it seems to be better compared to our methotrexate group. And they suggest that the patients in MMF has a better survival. And I think so. MMF is usually accepted to be a better conventional immunosuppressive compared to methotrexate. But there is, in fact, the most interesting data comes from leflunomide. There is quite a lot of open label of leflunomide data, especially from China. But this one from Brazil is especially interesting because it compares leflunomide to adalimumab, a biologic. Normally in RA or spondylitis, as you know, definitely biologic is the winner one. In this series, there are 15 months of follow-up, but leflunomide patients are quite older with significantly more disease duration. Now that's important. They might be the group with milder disease course, with slower disease course compared to the adalimumab one. However, their baseline activity is about the same. And they say that, although not reaching statistical significance, it seems that the patients under leflunomide seem to be better than adalimumab, at least not worse, definitely. And the drug survival seems better. As this is a disease with quite a lot of T-cell involvement, leflunomide seems to be a good choice, and we are using it a lot. And the control trials, except a failed abatacept trial, this is still the only randomized control trial in Takayasu. And in the first publication, it's just on the borderline on efficacy. About 50% relapse in 6 months. That's quite high. And this group, the Japanese colleagues who did this study, did not 0.1 and stayed there. Then their follow-up of up to 96 weeks, most of the patients stayed. And in the imaging, most patients stayed stable under tocilizumab. There is quite a lot of open label data. This is from France, your country, with comparing together with Italy, Spain, Israel, Japan, different countries. The first relapse rate and the drug discontinuation seems quite similar in this 200 patients. Drug discontinuation reaches to 40% in about 3 years and stays stable there. So definitely better than conventional ones. However, when we look at our patients comparing TNF and tocilizumab, about half of them, the main drug discontinuation rate is disease relapses. So with these two main biologics, we still have an unmet need. This is a recent series comparing adalimumab to tocilizumab from China. This is a head-to-head study, so it's important, but again, open label. But they had quite a high level of efficacy definition. In the 6 months, they aim less than 15 milligrams. That's too much for me. And in the 9 and 12 months, less than 10 milligrams. And in the 6 months, they say that adalimumab is better than tocilizumab, 85 to 52% efficacy rate. However, at 9 months, these numbers became closer, and especially the relapse rate and the patients under glucocorticoids 10 milligrams, which is a better choice, is about the same. So I don't think that they interpret it as the adalimumab better than tocilizumab, but probably the same again. Different from EULAR, suggests that TNF can be a first-line agent. And Only when the TNF and other conventional fails, and they only mention methotrexate and azathioprine, tocilizumab can be suggested. That's interesting. Why TNF inhibitors is recommended over tocilizumab as the initial therapy by ACR? They say that primary efficacy endpoint is not achieved in the only randomized controlled trial of possibly due to the underpowering, 36 patients. There is more clinical experience in the literature. And finally, tocilizumab use, as you know, affects acute phase reactants. So CRP becomes negative in all patients. However, we also have these patients, for example, with negative CRP, but on a severe chest pain at the end responding to steroids that we need to change the drug. So monitoring tocilizumab is difficult, and they say it as a cause for choosing anti-TNFs over tocilizumab. We recently looked at our patients whom from the beginning, which patients will require biologics. In a follow-up of 73 months, it seems that the patients who required biologics in our series are younger, with more constitutional symptoms, and a bit higher CRP, and they seem to have a higher rate of relapses as expected. So the biologic group is usually a younger, more severe group, and it seems that we can guess it from the beginning. Are there novel therapeutic options? Yes. This is a disease that affects macrophages, T cells, and agents such as anti-IL-12, 23, anti-TNF, of course, and anti-IL-17 can be options. Again, this is a series from China where they compared in 24 weeks secukinumab's TNF inhibitors, low patient numbers. In 3 months, it seems TNF is a bit better, but after 6 months, it's about the same. For me, we have tried secukinumab in a few patients. In TNF refractory patients, it doesn't seem to be very effective. IL-12 can be an option, and it comes out that in the JCA and Takayasu, IL-12B gene is a common risk factor. And the small 3-patient series from Japan suggested that it might be effective. There are a few more cases, but again, when we use it in refractory cases, both used anti-TNFs and tocilizumab before, it didn't work. But the most promising data come from targeting JAK-STAT pathway. This is the French study of first the JAK-STAT pathway activation in Takayasu with 3 patients responding well. And recently, 2 series are published comparing tofacitinib to methotrexate and leflunomide. It seems that tofacitinib seems to be better than methotrexate. The relapse rate is lower, but again, similar to adalimumab, have a similar efficacy to leflunomide. But this is a good option. And now the study over 60 patients, an RCT, phase 3, with upadacitinib is continuing from 5 different countries. The patient recruitment is finished, and I hope we can see the results this year. Finally, I'll mention about vascular interventions. When is it necessary? This is a 40-year-old female in our series with 15 years of symptoms, stable claudication, and this claudication do not change with biologics. What to do? There are a few cases of gangrene in the literature, but not much. And the ACR guidelines suggest that in patients with Takayasu and persistent limb claudication, without evidence of ongoing active disease, they recommend against surgical intervention. And that's usually the practice worldwide. However, the group from Vellore, George Joseph and colleagues, through many years, had a lot of intervention experience, and they published it in JACC recently. They have, in a group of 1,100 patients, 942 interventions. The interventions are done up to 5 times, And although the primary patency is only about 50%, the assisted patency reached up to 90%. The cumulative rate is, 83%. And they strongly suggest that in patients with even with stable claudication, that percutaneous intervention should be tried. In this context, we recently look at how the upper extremity function goes in Takayasu. For this, we use a test called ULEX, unsupported upper limb exercise test, developed for COPD patients, but validated in RA also. The patient moves in certain bars to different levels. And it seems that in patients with left or right subclavian occlusion in most of them, the time to do the ULEX, the time to do the LUX is lower because the patient cannot do it anymore compared to the healthy population. They make the test until they are tired of doing it. And it seems that in active patients, it is a shorter time. They can do the test lower. It is associated with age, with mainly left subclavian involvement, fatigue, and damage scores. However, no association with disease duration and steroid dose. And then we followed 24 patients with a mean 15 months to see how it will go on. And it seems that during follow-up, they didn't go worse. In fact, they fared better. Their time to do the test increased, not reaching to the healthy controls, but getting better. But interestingly, in patients with active disease during these 15 months, they got worse. They had a shorter time. And also in the ones with radiologic progression. So in patients with remission and no radiologic progression, the upper extremity function, also although lower, stays stable during follow-up. And as we don't see any gangrene also, it's really a difficult decision to give these patients to surgery or interventions. The intervention should be done in uncontrolled hypertension, aortic regurgitation or coarctation, and aneurysm repair, if there is symptomatic cerebrovascular disease or ischemic heart disease. These are the standard indications now. And finally, the cardiovascular events, they are increased in Takayasu. We know that. This is a series comparing the Turkish patients with the Mayo patients, and they have an increased increase of cardiovascular events. It's associated especially with traditional risk factors such as metabolic syndrome. And also the statin use, interestingly, shown from Korea, that has a negative relationship with the relapse rate. The damage in Takayasu happens from the beginning. This is from our series. Most of the patients have damage scores with claudication, pulse loss, brutes. However, in the follow-up up to 6 years, the scores do not change much. There are relapses, but they are not associated with damage. So I can say that Takayasu arteritis has a chronic course with remission and relapses. Damage is limited in early onset disease. MRA is usually sufficient to diagnose. New cluster analysis might be useful. Relapses are frequent, but whether they are associated with damage is not clear. Immunosuppressives and biologics are effective in most patients. I think mycophenolate and leflunomide seem to be better. TNF inhibitors in our practice is still the first choice, tocilizumab the second, and JAK inhibitors seem to be promising. However, long-term is still unsatisfactory with vascular stenosis, steroid-related damage, and cardiovascular events. Thank you. I'd like to thank all my collaborators during these many years, both in genetic studies. We are working together with the VCRC and Pittsburgh for genetic studies, and now there is the PET scoring system group TIDAI.
Thank you very much, Hannah, for this very nice presentation. And now the paper. Maintenant, si vous avez des questions pour Hannah, c'est l'occasion. Profitez-en, il est avec nous. On a cette chance immense.
Many thanks, Erika Schiller, for many thanks for your really nice presentation. I have some worries about the EULAR ACR criteria, classification criteria, particularly the cutoff of 60 year. Before it was for symptoms before 50, and now it's before 60. Do you agree with that? And how to deal with clinical case with arthritis isolated in a 55-year-old woman? Is that GCA? Is that Takayasu?
Yeah, it's a problematic, definitely. First of all, in your population and most of the Caucasian populations, GCA is much more common compared to Takayasu. So in any early case between 40 and 60 years old, it's highly likely to be a subset of GCA compared to Takayasu. In our case, we see GCA much less. In my clinic, we follow about 30, 35 GCA compared to over 300 Takayasu. So in any late onset cases, I can define between 40 and 60, who especially have subclavian involvement, but also with abdominal or aortic carotis involvement, we think of Takayasu first. However, when you briefly cut the patients below 40 and over 60, the clinical features definitely have differences in JCA versus TAC. Whether we should keep it in 50, I don't know. I mean, because they had a large data set, having, in fact, much more GCA in the DC was, I think, about over 1,000 GCA compared to 500 Takayasu. They prefer to put the level up to 60 years old. But this is, I think, more like biostatistics than the real life. In any case, with isolated aortitis, according to the age group, we think it's either GCA or Takayasu, and treated, in fact, in both diseases in a similar way.
Many thanks for your fantastic talk. I'm Chloé Comarmont from Lariboisière Hospital. And what is... Allô, oui. Accelerated atherosclerosis in Takayasu, and what is your expertise about aspirin and statin addition in management of treatment? Many thanks for your expertise.
In fact, thank you for the question, because in a way I left it to the discussion more, because both guidelines say that unless there is additional cardiovascular risk factors, do not use aspirin or statin, because there is no control trial. However, we know that, first of all, this is an inflammation of the vascular structures, and statins decrease inflammation and protect the endothelium. So even in young patients without high LDL, I start statins in all of them. And again, quite a lot of the time, we add aspirin to protect the thrombotic events. Especially, I observed that in Turkey, in fact, for example, smoking in the females is not too much, only about 20%. But if the patient is a 40-year-old female, refractory to treatment with calcifications on CTs, it turns out to be usually a patient with family history, hyperlipidemia, or smoking. So these traditional risk factors definitely affect, I believe, the course of the Takayasu. in females especially. So in this subset, we try to stop smoking, to treat hyperlipidemia, and also give quite frequently aspirin. But the data is all retrospective. In fact, in Takayasu, there's not much aspirin data, but in JCA, you know, there is data for it, but the guidelines still do not suggest it. But I think they should be part of the treatment spectrum. I'm waiting the question. I just want to show a picture. This is a temple in the most southern island of Japan, where Takayasu is born. He grew up from this village close to in the Fukuoka Island, and his father was a priest of this temple. Last year, they made a meeting bringing together Japanese, Chinese, and the Uplar group. Unfortunately, we lost Debashish Tanda from that group. He had a hard life. Takayasu came out of this village and went to the Tokyo University, newly formed at that time in the Western style in the 1870s, and graduated from there, and in Germany educated to become an ophthalmologist, and returned back and defined the disease.
Thank you very much, Grégory Punier from Toulouse.
You mean immunosuppressives?
Yeah.
Definitely. First of all, for time reasons, I haven't shown it, but if you give the patient to interventional treatments in the active phase without treatment, definitely over 50% will occlude. This is shown in the literature a lot, and it's our own experience. So if it's not an urgent stand, for example, if the patient seems to be getting a stroke, we want the cardiologist or radiologist to postpone their intervention at least for a month or so, that we give first steroids and then the immunosuppressives, if possible, over 3 months. And definitely maybe not under steroids in each patient, but conventional immunosuppressives, or if it's a case with more serious involvement, especially aortic involvement, it's usually under biologics. The patient shouldn't go to intervention without treatment.
Did you want to mention whether or not methotrexate or additional immunosuppressant should be added to TNF blockers and tocilizumab?
In our series, combining them with biologics doesn't seem to improve the drug survival and the efficacy. However, as in other diseases, especially for infliximab and adalimumab, we definitely add it with the conventionals. And in these days, most of the time we are choosing leflunomide for this.
Thank you very much, Divi Kornek from Brest. In terms of infectious complications, do you have the feeling that it's as frequent as in other forms of vasculitis? And specifically on pneumocystis pneumonia, do you prevent it systematically in all patients?
There is some data in the literature saying that, in fact, the infectious complications with TNF blockers is not different compared to the other series. In Turkey, we are usually worried about tuberculosis because the tuberculosis rate in our population is higher than Europe. And with TNFs, we have a higher rate. However, it didn't seem to be a major problem for us. And also, I haven't seen a pneumocystis carini case. And I don't think there's much in the literature about that. Of course, as both with TNF blockers and the tocilizumab, there is an infection problem. But in our series, I've shown, I think it's only about 10% that relapsing various types of infections led us to stop the drug. Most of the time, we can handle it.
Yes. A question from a nephrologist on Takayasu. That's for nephrology. Are you worried about the cardiovascular effects of JAK inhibitors in this disease? Because you have mentioned that maybe it's the feature of this treatment, but we know now. is that there is some toxicity on vascular side. So what do you think about that?
Yeah, that's really for tofacitinib, it changed the spectrum. For example, for tofacitinib, we were nearly starting a trial for Behçet's disease, but the company said that at the same moment that the trial came out in New England, and they just didn't want to make the trial. For Takayasu, we are a bit less worried. And until now, these small case series did not give a worrying signal. And as you know, although this is clear for tofacitinib, for the at least retrospective data from baricitinib and upadacitinib, it doesn't seem to be a problem. And the safety signals in this 60-patient clinical trial of UPA, although not published yet, there is no problem with the increased thrombosis at the moment.
What are the specificities of Takayasu patients associated with Crohn's disease?
Now, usually Crohn's comes first. In fact, for all spondylitis cases with Takayasu, around 10 to 15%, the spondylitic features like back pain, psoriasis, or IBD comes first. Sometimes it can be quite severe, but at one point in their course, 5 to 10 years usually later, they begin to have some constitutional features and an unexplained acute phase response, and it was realized that they have Takayasu. That's the usual scenario we've seen. Whether they are more severe, in terms of spondylitic features and the inflammatory bowel disease, they don't seem to be too refractory. However, we had a few refractory aortitis in these cases. Because TNFs is the only current choice as the biologic, if it's not sufficient, it's a bit problematic.
Thank you very much. I think we have to move on. No, you have a question, Xavier?
Yeah, I have a last question maybe. I'm talking about the patient who are asymptomatic with elevated acute phase reactants. Do you think there would be room or window of opportunity to have a randomized controlled trial evaluating increased interventional immunosuppressant versus wait and see?
Great idea, really. That's the French approach. I know the vasculitis group looking at the niches, definitely. I mean, and ethically, it would be a fine study. I think all of us in Turkey, we have patients like this, that we don't decide whether to increase the immunosuppression, especially passing the biologics is a difficult decision in an asymptomatic patient. A trial, an investigator-initiated trial aiming to look at this support, the group, whether to increase or not, would be very nice. We should think of it.
Okay, so thank you very much. We're going to applause you again.